Today we are super excited to hear from Nuria and from Paul. And so for the rest of us, if we could mute ourselves so that if there's background noise or whatever, it won't interrupt. So I think looks like everybody's, just about everybody's muted already, maybe, yeah, except for me. So I get to introduce am I still muted? No, okay. Okay, so I get to introduce my friend Nuria today. I'm so excited that she's here. And Nuria is such a great connector that she reached out to Paul to have him join us today. So some of you already know Nuria. Because we're friends, we talked a little bit about what would be a great topic for her, given the publication of her book on decoloniality. And so she came up with the idea of talking about decolonial approaches to prevention and health promotion from a community psych perspective, and then Paul will add the public health perspective. And Nuria is a professor in community psych, liberation psych, indigenous psych, and eco-psychology at Pacifica Graduate Institute, which is in California in the United States. Having grown up in Mexico and earning her bachelor's there as well. Later on, Nuria went to Germany and earned a master's in clinical and social psych. And then we met each other in Hawaii, where she was ahead of me in the PhD program in community psych. And while she was there, she also got her master's in urban and regional planning. And then has since gone on for about 40 years working in indigenous psychologies, both in Hawaii and Mexico, and now in California. And then Paul is a postdoctoral fellow, like he said, in the Department of Medicine in Michigan. And he is also affiliated with the Mixed Methods program. So it's really great to have a public health professional with us speaking today, especially because this area is also in health inequities, race, and culture. These things that kind of intersect with what we do in community psychology. So with that, I will mute myself and hand it over to Nuria.
Thank you very much, Susanna. That was a lovely introduction. Thank you for inviting me. So nice to be with you here today. And thank you for all of you who patiently will listen to both of us. I just would like to warn you that, well, at least my presentation may be a little too critical of some approaches in community psychology in the US. As Susanna said, I come from Mexico, and will present to you the, well, advancements from the global south, so-called global south, that is now contesting things that have happened in the, from, you know, scholarship from the north. I will share my screen with you, and bear with me so that I hope, can you see it? Yes? Okay. So I'm going to start now focusing more on the community psychology approach. And since, as we know, community psychology has learned much of its prevention and promotion strategies from public health, I was fortunate to run into similar work that Paul in public health has conducted. And this is why I'm going to leave that part to him. I would like to start by pointing out that community psychology has hegemonically been located in the United States in you know, hegemonic scholarship, whereas the global south has contested this ownership of who owns the womb of community psychology, given that way before the Swampscott Conference, many countries such as Latin America, Asia, and Africa, there was work done in community psychology, primarily conducting community-based participatory research, addressing social inequities that had to do with colonization. So colonization became central way before, or maybe even so much before and in more strength than in the US, and mostly not in in the community psychology here in US. So I will refer to CP, so to shorten the time when I refer to community psychology, to not repeat it over and over again, and also to CP, the US-centric CP, referring to the power that community psychology has already gained worldwide, as opposed to that emerging from the global South. So it is my understanding that in an intent to move away from individual approaches to mental health, as it was, part of the movement away from clinical psychology, community psychology, CP, US CP started to look at models in public health and took over approaches, prevention approaches such as primary, secondary, tertiary prevention in its planning and programming from large-scale initiatives, multi-site initiatives. In this way, for example, primary prevention was associated, or has been still associated, with the ideology of systems change and education, whereas secondary prevention targeted specific populations that are determined to be at risk. And it happens that most of those populations are Black, Latin, and Native American. And that's proportionally most frequently assigned to this category compared to whites. Then tertiary prevention strategies are designed to lock these populations in hospitals, prisons, or to receive diagnosis and treatment. Programs, strategies, and initiatives to reduce poverty, homelessness, and crime then are designed, implemented, and evaluated in multiple sites and viewed as effective programs or best practices that community psychologists need to promote and disseminate. Whereas colonized countries such as Latin America, Africa, Asia, the Pacific Islands, Indigenous Australia and New Zealand have applied an interdisciplinary social and civil rights movement approach in comparison to USCP. In the United States, for instance, during the 60s, prevention programs that emerged from multiple disciplines began to be designed and implemented also within community psychology's field. For example, the Head Start program that addressed the war on poverty regulated by the Johnson's administration. Here it is important to note the connotations of war, that were also appropriated for supposedly humanitarian purposes to alleviate diseases. There need to be a war of poverty or a war on drugs under the Bush administration. Head Start programs, for example, were designed everywhere, including not just across the United States, but also internationally, to target school readiness of marginalized preschoolers, who again happen to be mostly Black, Latin, or Native American. Whereas these children had to learn, acquire language skills that resemble white middle-class standards and linguistic competencies. Intelligence tests have been developed as well to assess skills, cognitive competencies praised as superior by white Western culture. For instance, the Wechsler Intelligence Test for Children was applied everywhere, even supported by large organizations like UNICEF in different cultures, to measure the increase in intellectual capacity of the Head Start children. And these strategies then were exported as solutions to poverty. Whether these were colonized or colonizing countries, it was irrelevant. What was and continues to be relevant since the beginning of US-centric CP is that populations and societies exhibit competencies that preserve and maintain the ruling economic system of corporate and global capitalism and its continuation in coloniality. Aníbal Quijano viewed coloniality as an existential state in which power is exercised as the most effective oppressive strategy used by Western white and male colonizers to usurp indigenous lands and peoples. Bodies, knowledges, religions, and spirituality. In this process, the conquered are labeled inferior and the conqueror superior, creating thereby a racist hierarchical system that maintains the colonial difference, as Mignolo stated, or what Boaventura de Sousa Santos, who both are scholars of the Global South, consider the abyssal exclusion of Western knowledge systems, beliefs, and existential practices, as well as the exploitation and extraction of land and ecological systems, causing epistemicide and ecocide, respectively. So in these ways, it manifests in our current times as modernity and Western epistemic universalism. Poverty and intellectual ability were and continue to be correlated with the need to design and implement Western educational programs in order to address the causes attributed to race and ethnicity under civilized standards determined by white supremacy with the intent to maintain and preserve progress and civilization. 50 years of US community psychologist history have passed, and we barely hear colonialism and coloniality being named as the root cause of the large-scale problems community psychologists, prevention and promotion programs and strategies seek to eradicate. Moreover, its ameliorative, not transformative strategies and approaches target populations that do not cope with the exigencies and oppressions of the brutal capitalist system for them to adapt and contribute to its preservation in order to be healthy and live well. For instance, as it was referred earlier, large-scale drug use prevention has included educational programming to boost academic achievement as rhetoric for capitalist functionality. Moreover, it has also included war as a pivotal strategy, an example of which is the large-scale initiative War on Drugs that was carried nationally and internationally, becoming one of the most powerful tools the imperial power of a country could apply to control souls, bodies, neighborhoods of undesirable races and entire countries that need to be controlled in order to promote so-called population and political health, read it democracy, as well as the global economy. National and globally exported research selects populations at random under experimental and control group designs to create and archive so-called best practices emerging from positivist paradigms that are deeply rooted in coloniality. In this way, science contributes to the effective functionality of what is called the modernity coloniality matrix. The complicity of USCP with modernity explains why the analysis of social ailment prevention and health promotion approaches lists risk factors of community health caused by poverty, such as domestic abuse, neglect, and foster care cases or crime rates, among others, whereas racism and coloniality are unfrequently referenced. Barely there is mention of poverty being caused by racism, which originated in colonialism and continues to exist in coloniality. Miller and Sheen pointed out that the failure of prevention models is due to programming, implementation, and dissemination difficulties because such models are created by experts under strict control conditions. And the communities have difficulties understanding them or even resisted to adopt them. They don't reflect their context, culture, and needs. Consequently, it is assumed that communities have limited capacities and they need to receive capacity building in translational research without addressing the potential incongruence of values and knowledge systems between the institutions that produce these practices and the communities that are required to implement them. Earlier in 1981, Rappaport critiqued such a process as one-sided, deriving from needs instead of strengths, driven by expert-based, top-down instead of community-based models, and insufficient to effect institutional change. Instead, he advocated for the application of civil rights. Another violent example is what we are experiencing in our current times. The number of COVID-19 cases causing serious illness and death is dramatically the highest among African and Native American communities and higher among Latin compared to white communities. This same pattern is replicated in the multiple consequences of the pandemic effects on the economy, causing a rapid and exponential increase in unemployment and poverty rates in these communities compared to the white population. A microscopic virus amplified the existing racial disparities into such higher proportions that it is no longer possible to deny them. Likewise, it is no longer possible to deny the entrenched pandemic of racism manifested in police brutality, among many others, that has existed for centuries since the Native American genocide, the slave patrols, and the immigration persecution against Latinos and Asians. However, it is performed as if it is now that racism miraculously raised into national conscious awareness, while having been deeply entrenched in the collective unconscious to maintain the white supremacist empire. What kind of preventive measures need to be applied to stop this kind of violence? One aspect appears to be clear: pandemic prevention measures can no longer be universal, assuming equal outreach to an entire population and expecting equal outcomes. So, what needs to be done? Let's begin by naming that the main root cause of human suffering is coloniality. The epistemologies of the Global South propose to co-create alternatives to modernity as opposed to alternatives of modernity that exist at the margins of the unaltered system. Alternatives to modernity require a commitment to the link from colonial ideologies and practices that are created and maintained by hegemonic institutions and venues, including the academy. US-centric community psychology is no exception. It has been critiqued as an imperialist, elitist, and monolithic discourse. Envisioning alternatives to modernity requires the need to co-construct potentials of decoloniality with community partners. Learning from the application of these potentialities can inform an emergent definition of decolonial wellness promotion and illness prevention within a linked community psychology. Decolonial prevention and promotion needs to be conceived as liberation, envisioning frameworks that originate from the grassroots and from pluriversal and indigenous knowledge systems that empower the individual and community agency and self-determination to question and dismantle oppressive systems. For instance, we can learn from communities their own prevention and promotion strategies anchored in their cultural legacies and systems. We need to focus less on programs that are conceived in the academy under governmental or non-governmental research institutions and then implanted in communities worldwide, regardless of culture and structural institutions. The focus needs to be on dismantling the still existing structures of coloniality that cause the very issues we want to address. The actions that the communities decide to take will not target individuals, but institutions and their mechanism for just resource distribution. The type of questions that will emerge will not be how do we prevent people from becoming homeless, but rather how do we prevent our governments, communities, and institutions from causing and maintaining homelessness. Prevention strategies will only be valid and reliable in the limited localities in which these emerge. And this will target the civil right of individuals to have a home rather than the individual's competencies and skills. Policies will look at living wages and protective unemployment benefits. This is in contrast to ameliorative strategies that adjust the individual to what the Zapatistas in Mexico call the capitalist hydra. We need to learn from indigenous knowledge and health systems that have been erased and silenced within hegemonic scholarship to crack this aggressive catastrophe with multiple heads. Community-based participatory research has purported to generate community engagement, agency, and ownership of health promotion by including the community's knowledge and praxis systems in research, design, implementation, and evaluation. There was a time during the late 2000s when we will see CBPR as requirement of requests for proposals published by NIH, NIMH, CDC, and SAMHSA. However, to date, the language has changed to expert language. Scientists are looking for translational research so that the communities can understand their jargon and fallacies created in the scientific apparatus in a one-way process of banking education. This is another evidence-based proof of coloniality. The only venue we have to address these pervasive tendencies is to conceive transformative change as one that delinks from Western hegemony and its axiological and epistemic apparatus. It is not about executing liberal hope by offering ameliorative fixes manifesting in benign reforms and governmental regulations that continue to feed the hydra. It is about epistemic justice and the co-creation of the otherwise, the not yet, what we cannot visualize, what exists outside of the hydra. Prevention and promotion need to target the structural causes of oppression and marginalization, dismantling coloniality as the most pervasive ecological root cause and its correlated symptoms such as racism, sexism, heteropatriarchy, ableism, ecocide, and epistemicide. This is an imperative condition to promote social justice. Irma Serrano Garcia has added that community psychologists have a duty to address coloniality and colonialism in a recent article published in the American Journal of Community Psychology in 2020, this year. It is not about changing individuals, families, or communities, but the hegemonic societies and institutions, including the academy and its disciplines, that create and maintain coloniality. It is about co-creating the colonial possibilities that dismantle power structures, weaving networks of decolonial solidarity with communities and social movements to learn from them and create the otherwise. It is about centering local knowledges and practices that embrace the promotion of non-Western, non-hegemonic, indigenous well-being, buen vivir, summa causae, beyond ethnocentrism and anthropocentrism. Thank you very much for listening.
Thank you, Nuria. That was a wonderful presentation. So many thoughts that are going through our minds right now. And if you guys can just take a moment to think of what your questions are going to be for Nuria at the end. We'll go on to Paul's presentation and then we'll do the questions afterwards. So just take a note while Paul is bringing up his slides as well.
Can everyone see my PowerPoint? I hope you can. So thank you very much again for the invitation and for being here. And on behalf of myself and Suba, my colleague who unfortunately could not be here today, we do want to first recognize that perhaps humbly so that we don't view ourselves as the experts or inventors of decolonization, but we want to help synthesize from the literature the key elements of decolonization that might be useful for health promotion practice. And to help save the bandwidth, if that's okay, I'm actually going to turn on my camera. So I want to first acknowledge that where I am presenting stands on the traditional territories of the Coast Salish and the Duwamish people. We don't just end with this recognition, but view it as one of the many drivers of what we do in pursuit of health equity and social justice. In the relatively little time that we have, we'll discuss the background motivation for our framework, walk through the elements of the framework, and then talk about the possible application and end with challenges and next steps. And this is much of our discussion is laid out in this more detail in our publication with the link I provided below. So what sparked our interest in doing this was that during our public health training, we were exposed to a variety of social science pedagogies. And within these disciplines, the concepts of colonization and decolonization came up frequently. However, within our own discipline,
drink it.
it was infrequently discussed or even named. This is despite the fact that the colonial legacy or the systemic exploitation and erasure of oppressed people
okay, I'm sorry.
contributes to past and present health inequities. And this is a similar concept to coloniality that Nuria mentioned. Moreover, as Nuria discussed, many tenets of public health, promotion, or even public health practice are developed from an expert-driven model of knowledge dissemination that could undermine the wisdom or experiences of communities. To help frame our discussion, I want to read out the following definition of decolonization from Wazi, Yadawin, and Delabert, who define it as the intelligent, calculated, and active resistance to forces of colonialism that perpetuate the subjugation of our minds, bodies, and lands, and it is engaged for the ultimate purpose of overturning the colonial structure and realizing indigenous liberation. To me, I want to point out that the emphasis is on individual as well as a structural process to address the forces of the colonial legacy, and it's both about the thoughtful engagement and active resistance. So why proposing our applied framework? So we found that Indigenous scholars have developed guidance on the strategies of decolonization, but the application is narrowly applied to specific health areas, perhaps in an Indigenous oriented intervention or a training program. However, we don't see these principles applied across health contexts or across a range of health promotion activities. Therefore, we argue that there is inadequate integration of decolonial processes in the field of health promotion and public health. And for practitioners, stakeholders, or trainees working in this area, there is relatively little guidance on how the field should engage in the process of decolonization to achieve health equity and social justice. As a result of our scoping review and content analysis, which we unfortunately don't have time to go over today, we drew upon the key themes and elements to develop the framework presented to you. It is shown in this diagram that organizes the constructs by 3 common primary domains: reflection, planning, and action, each with its own constructs or elements. I will deconstruct this model, going over each element of the model. And for each of the element, I will provide illustration of how it is enacted or implemented in the literature that we found. Starting with the reflection domain, this domain reflects on what influential scholars cite of as, or describe as reflecting on the colonial legacy and its effects. It consists of 3 constructs, including assessing the effects of colonization, critiquing current paradigms at multiple levels, and decentering the frame of reference to marginalized peoples or communities. First, assessing the effects of colonization involves examining the long-term, multi-generational effects of colonization on health and well-being that are reinforced in present day and often are unchallenged by people impacted. As an illustration, the work of Weaver pointed out that the gradual loss of Indigenous sovereignty from legislative, judicial, and forced acculturation could over time foster the conditions of disability among Indigenous people as we come to understand it today. Second, critiquing current paradigm requires that we examine the historical, cultural, and epistemological influence of the colonial legacy on the contemporary practices, assumptions, and perspectives of health promotion. And this occurs at multiple levels, from the level of practice to that of the individual practitioner. As an example, Huntington's work on decolonizing practice demands that nurse practitioners critique the biomedical assumptions of modernism embedded within the discipline. Third, decentering the frame of reference involves shifting the paradigm of health promotion practice towards those individuals impacted by the colonial legacy, and recognizing that those individuals may be at the intersections of economic, cultural, political, historical, and racial forces, and are differentially vulnerable to these forms of oppression, speaking a little bit to the concept of intersectionality. As an illustration, the African community-based research methodology that Iba Kiwanlan and McGrath proposed aims to integrate African perspectives into CPPR, including emphasizing the intimate connection between the person and the community, the relatedness of the individual and social knowledge, and the identification of the person with the environment. Now moving on to the planning domain. So this domain prioritizes the intricate and dynamic steps of planning decolonial actions that we think merit its own sort of domain or group. And it includes the process of engaging in mutual dialogue and honoring wisdom with accountability. Engaging in mutual dialogue involves facilitating respectful and transparent dialogue with communities that are grounded in trust and reflecting on the colonial legacy on past and present well-being. As an example, the use of Indigenous Learning Circle and Wexler's Indigenous Suicide Intervention illustrated in that much less of the learning circle is didactic, and the majority of the time is dedicated to sharing stories on suicide experiences and discussing how participants can apply these collective insights to their own communities. Honoring wisdom with accountability requires that we safeguard the knowledge and resources of community experts as intellectual properties in themselves. As an example of this, in relation to food justice movements, Bradley and Hilera argue that decolonization involves formation of a health perspective in which practitioners privilege the theories, values, needs, and interests of marginalized communities in order to advance the interests of the very people being served. Finally, the action domain is an inherent call to action that emphasizes organizing collective resistance to liberate people from the binding forces of the colonial legacy. This includes three elements: mobilizing communities and building alliances, engaging in social justice practices, and placing self-determination at the core activities. A key element of decolonizing efforts is bringing together the community members and stakeholders affected by similar intersectional forms of oppression. And this might include the members of the majority group reaching out to those impacted by the colonial legacy. To illustrate, in discussing the process of decolonizing queerness within Indigenous settings, Hunt and Holmes emphasize that nurturing everyday relationships with Indigenous, queer, trans, and two-spirit community members will help to contextualize decolonization efforts within their political struggles in a way that Indigenous stakeholders identify with. An integral part of social justice element is to engage in anti-oppressive or prevention practices that actually tackle at the root causes of health inequities. As an example of this, McGibbon and colleagues explain that such social justice acts should address institutional racism and actions that maintain colonizing social structures within a given setting. Finally, honoring self-determination as practitioners or stakeholders who plan and implement decolonizing health research or intervention activities promotes self-determination of community members as the end goal of these activities. An example of this is in Mundell M. Chapman's Indigenous Community Kitchen Garden project that used Indigenous medicine wheel, as well as building of awareness of colonialism and celebrate Indigenous cultures. As a result, program leaders and participants perceived that it allowed them to practice the concept of holistic health in their own cultural terms as a step towards self-determination in terms of health. Now I want to return to the framework with all of these elements. When all of these domains are engaged, we consider it to be full engagement in decolonization. But I do want to give a few pointers about this schematic. First, the framework is meant to be iterative in its application. Specifically, the overlapping nature of each domain indicates that the work employed in one domain could affect processes in another domain. Additionally, as you might see in the arrows, it reflects the notion that the processes are not sequential. For example, mobilizing communities and bridging alliances in the action domain may depend on continued engagement in mutual dialogue within the planning domain. We want to share a few other considerations. First, this framework should be treated as a roadmap. Therefore, it is not desirable to be employed with strict fidelity or as a prescription. It is of paramount importance that we tailor the framework to the community that you're working with, the resources that are available, and their very own interests. Additionally, although the outcomes of any project or intervention might be important, the assumptions that we bring to how we conduct this process must also be challenged. Finally, other critical and participatory methodologies, including CBPR that Nuria mentioned, or critical race theory, can be used in conjunction or synergistically with this framework in order to advance its use. So underlying the decolonial framework are three core values that we think might benefit health promotion transformations. First, the framework encourages practitioners to pay attention to the historical legacy of the colonial legacy and its effects on well-being. Understanding the historical context of suffering allows practitioners to grasp the very impact on the lives of those being impacted by the colonial legacy. This is particularly salient when trying to untangle the often subtle effects of the colonial legacy from the past and the present. Second, the framework regards local wisdom of marginalized communities as valid forms of knowledge that should be utilized through active participation or engagement with knowledge owners. This is a shift from the idea that knowledge of the dominant group is foundational, as I mentioned earlier, And it may move the practice of health promotion towards reconceptualizing its epistemology and minimizing historical exploitation of Indigenous knowledge. Finally, the framework urges the employment of social activism to undo the effects of the colonial legacy. Upon developing awareness of the colonial legacy and engaging in mutual planning with marginalized communities, the model responds to the calls to social actions embedded in the agenda of decolonization. We do admit that there are multiple challenges when applying this framework, but want to highlight a couple of key ones. One of the barriers of embracing critical awareness of the colonial legacy is what Porter referred to as colonial amnesia. Specifically, those impacted by the colonial legacy may lack explicit awareness of the effects hegemonic influence of colonialism on their lives, because the traumatic experiences of colonialism may be too painful to pass on to later generations. Therefore, recognition of the colonial legacy may not necessarily translate to a sense of collective agency. Second, as illustrated by elements of neutral dialogue and community mobilization, the framework is intended to be applied with significant participation by community members and stakeholders. Using this model as a prescriptive or a descriptive endeavor may undermine the primary values and principles of decolonization. Finally, implementing specific processes in decolonization may not be straightforward or intuitive. Additionally, it may not be linear. Those employing the framework must be cognizant of that engagement in the process is far from smooth or complete. To bring this home, we want to view this framework as groundwork for stimulating a transformative dialogue, at least in our own discipline, what it means to decolonize public health and health promotion. We encourage a holistic application of the model that moves beyond the level of practitioner to that of the discipline. We also advocate for the application with the spirit of innovative and collaborative solution building that truly embraces community wisdom and self-determination. And that is it. I apologize for going so fast just to keep on time, but hope I can answer any questions that you may have.
Paul, thank you so much for giving us a really broad overview and for your framework and how your work with, as well as Nuria's work, there's so many overlaps there. We originally planned to have the call go till 3 o'clock. Well, that's my time, so for an hour. And so Jean, is it all right if we go a little extra? I'm not sure if somebody has this line booked, but if we could go a little bit extra.
You can go as long as you want.
Okay. Alrighty. So in that case, maybe if you folks have a question, if you can use that little reaction thing and do like a hand wave or the clap or the thumbs up. And then that way with 20 some odd of us, we can open it up for some questions or comments. And let's see, I'm not seeing anybody using, oh, there we go. So Louisa, go ahead and unmute yourself, please.
So I, first of all, just want to thank you both for your presentations. They were fascinating and actually really helpful right now. I am in the process of, you know, as I mentioned before, going through this project, which I love and I'm passionate about, and you know, it's my community that I'm working with, and it's been a real struggle to I think get people at my institution to realize that the more decolonial messages that I'm trying to push through are legit, you know. So when I'm trying to not just do things that are quote unquote positive youth development, right? Like the more traditional positive youth development. And I'm wanting to do something with my Puerto Rican youth participants that is truly transformative. It's been very difficult. To see the support here has been very helpful. So I just want to thank you for the work that you're doing, and encourage you and everybody else to keep doing it, because it's so needed and appreciated.
Nuria or Paul, if you want to reply, then please go ahead. And then if other folks have other questions too, if you just kind of use the thumbs up thing, and then I'll call on you after. And Louisa, thank you for sharing. Go ahead, Paul. I can see you're unmuted.
Yeah, thank you. I very much appreciate your courageous work, and want to encourage you to keep going. I know that this is really difficult. As you can see, we did this work because none of these concepts are mentioned in public health. So what we do is, and I don't know if this is helpful, but a couple of things, we really start to do piecemeal projects. So, first we'll do a scoping review, then we'll start to build the model, and then as the next steps, maybe collaborate with others to see how it could be useful or not useful. So that's like a way of sort of like having this grand project, and then do little pieces that you can do in the time available. And then second, you probably know this, but I want to share my mentor's advice is, find an ally within your discipline or your department. It's really tiring to do it alone, so it's a little better to do it with a shoulder to lean on. That's all I have. Thank you.
And Luisa, I think that the youth are our hope. And my experience is that they get the concept immediately. It's like, wow, yeah, I know that. So that's how you call it, right? And they can say it louder and clearer than we do. So that's my hope, that we can bring to those generations this awareness, and we do the work with them.
I think the other thing that I was thinking about as you were talking, Louisa, is positive youth development. That concept is kind of new, just in this century, really. I think people were doing what they considered to be positive youth development, but it wasn't coined so much as like a thing for us in psychology and public health or social work to do. And so the idea that positive youth development may not have these concepts of decoloniality in them, I guess to me it doesn't really matter, because we're doing it anyway. And by having the work of Nuria and Paul and you to bring it into the forefront is what really matters. So like Nuria and Paul said, just keep doing the good work, and use the concepts from Paul's paper and Nuria's book, and continue to reframe it with those youth voices. I think that's where the change is gonna come from. It's not coming from the top, that's for sure, because they don't want that to happen. Right? But we in this Zoom room can make these things happen. Let's see, thank you for bringing up that important question. Let's see who else. Anybody want to use a thumbs up or just unmute yourself and share your view? Oh, Jessica.
Hi, both Paul and Nuria, thank you so much. I think at the beginning of this presentation, I had mentioned that I work with tribal Head Start programs. And I think one of the main questions that came up is, how can I work in these spaces while aiming to break down and not continue colonial acts? Because as you mentioned, Nuria, Head Start programs were created against the war on drugs to meet white standards. And I think I am in these spaces, I work in these spaces thinking about that in the back of my head, but I'm just the smallest, tiniest piece of this part of the whole governmental run program. And so I can work with my supervisors all day long, but they also have to meet certain standards from that is the government and these government funded programs are imposing. So all that to say, going back to the question is, what do you have, both Nuria and Paul or anyone else, do you have any recommendations on how can I work in these colonial spaces, just as anywhere, but specifically Head Start programs, and start to break down, start to be decolonial in the way that I'm working, the way my supervisor is working, etc.
Yeah, thank you, Jessica. That's really a good question. And it's a tough place. You know, I think we all are working within coloniality. It's a huge elephant. It has existed for so many years. You know, it's not going to happen like from one day to the next. It will take generations, maybe 7 generations, like the Indigenous elders say, you know, to change it. But I think if we start, each of us, changing some little things within our own practical work, you know, I can only share, you know, when you said you are now working with those kids, I was funded also by the UNICEF to go to work with Indigenous children in Mexico who and follow this, the Wexler intelligence test and all these prescriptions, but I will then, like Walter Mignolo says, practice epistemic disobedience. You know, I will disobey when I found so little cracks in the system. You know, maybe when you are with your group of students alone or doing your own praxis in those communities, I would change the talk about doing the Wexler with them, the intelligence test with them, instead asking them to bring their own toys, you know, or design their own games, and they're starting to acknowledge their competencies and skills in their own systems instead of trying to do the top down, and practice that disobedient space as much as you can, where the children get the message, you know, and the appreciation that it comes from their own cultures. And then, well, I think we have to use the academy and organizations such as this one that is actually very powerful to allow us to bring that awareness, you know, to policymakers as well as to scholars and practitioners, and do the work that way. And Paul has maybe other advice.
Yeah, so I will humbly acknowledge that I am a researcher in community health with no expertise or anything to speak of in your areas of practice. But a couple of things I think about is even within my own, I work in a traditional space, but what can I do at least to challenge the assumptions or the how of, you know, the principles of how people do health promotion or community-based work. Because when people assume based on their own preconceptions or understanding, that's one of the ways that health inequities get perpetuated, or social inequities. The other thing is that I think about the very definition of colonization or the colonial legacy as the systemic erasure of people's wisdoms and knowledge, right? So I think about what can I do to maybe not the best word, but erase that effects. And I think it speaks to what Nuria mentioned, you know, to draw out, to work with and build capacities of the participants, the youth that we work with, and draw out those Indigenous wisdoms or ways to do things as a way to challenge the system that you're working with or against. So those are my thoughts.
That works. I have the ball rolling. I have ideas and I'm thinking, so I appreciate it. Thank you.
Let's see if there's some other folks who would like to bring up some questions from your own work, your own coursework or professional practice.
This is Stephen Merced. And I can tell you, I think that the graduate students who are on right now, or other level students, are really as Nuria said, the power. We did a study about 5 years ago in the University of California system where we looked at how participatory research is being practiced and promoted. And we were amazed that the strongest advocates for that work were graduate students, and many of them throughout all 10 campuses called for more training and more support for this kind of work. So I would just reemphasize that. And I would also reemphasize, I think what Nuria, you said, is that this group does have power. I'm not sure, I've seen some other CRA groups do policy statements. I'm not sure if we as a group would feel comfortable as a prevention group putting out a policy statement for what would, sort of decolonial practices of a university might look like. And I think many of them were articulated extremely well by the two presentations today. I mean, I can't say enough good things about what I just heard. So I think there's so much there that would be very easy to borrow from and create a policy statement for this group as a starting point, and with an emphasis on training, not just ourselves as active practitioners, but also the new generation of graduate students that are coming.
Yeah, thank you so much. So that sounds really exciting and promising, you know. I mean, it really can make a huge difference. I think that's how all those movements were brought, you know, and in essence, community psychology in the US had a huge power. Tom can tell us, you know, during the 60s and 70s to change the contents of conversation, like the Global South scholars say, you know, the terms and content of the conversation, and start directing the education in a different way. Definitely. It's in your hands, the graduate students' hands. I'm seeing that happening with those who are here today, who are working with me. You know, they're making the road, and I'm sure many of you are doing that too.
And I will just pop in and say, and Jean, feel free to correct me if I'm wrong, but we can create statements as a group if that's something that folks are interested in. There's lots that we could do moving forward if that's something that folks on this call or other folks that people might know are interested in doing.
Absolutely. And I really want to make sure that all of our committees and interest groups know that. I can talk you through the process. I can hook you up with people in the policy committee who will tell you about the process of writing a statement. The idea behind writing a statement is that you see an area where you feel that a community psychology perspective is missing, and you then present that perspective. So it can basically be anything. So if that's something that this group is interested in, I'd be more than happy to give you some more resources, get you to talk to some people who have done it. So.
Steve, I don't think we have, or maybe Kayla has your email address, but if you don't mind to put it in the chat in case we don't have it for any follow-up.
Sure, I'll put it in the chat. Yeah, that's
right.
great.
Everybody sees it, but yeah, and then I think we have a time for one more comment or question. If anybody would like to jump in now, we have a little bit more time if Nuria and Paul have a little bit of extra time.
I just wanted to say, listening to the presentation, what really gave me hope was there's a lot of discussion, particular in social services and other fields, around racial equity, dismantling systems of white supremacy. And my fear is that there hasn't been a tool. So when people talk about it, it sounds more like a checkbox or traditional diversity training, but not what you guys are presenting. And so I don't know if it's a policy statement or just as people continue to do presentations to make that link to say, we know these systems have to come down. Here are frameworks of how you can assess your system so that we do leverage the energy of this moment to make transformative change and not just appeasement, which it feels like without your voices being heard on kind of this national conversation is where we will end up at. So grateful to you, but would love to see that link with so many. I see it in social services, from homelessness to domestic violence, to the youth programs, to community, alternatives, to policing, so the reentry and social justice. But no one's talking about the tool of how do you even identify systems of systemic racism, let alone how do you begin to kind of assess and diagnose so that you can begin to bring those systems down.
We lost you a little bit. I don't know if everybody had, I had a little bit difficulty hearing you.
Is this better? Sorry, I have background
Yes.
noise. No, just saying to make the link with all the conversation around racial equity that's happening right now, that people are talking about challenging these systems to bring them down, but I think we're lacking the tools. And without the tools that both of you presented, we're just going to do a checklist approach around diversity training or kind of tokenism, but we're not doing system change. And I think a link to some of the racial equity conversations, particularly among those in social services, from domestic violence to the prison reentry to the youth, defunding police initiatives. I think this, both of you and others in this work, provide such a valuable tool that would love to see that amplified in some of these other conversations. So we really harness the power of this moment and not just do kind of a tokenism event, but we really make some change.
Yes, thank you, Alisa. Yeah, I mean, like I think Sergio mentioned, there is movement happening in other places, and there's already a good number of us, trying to see how can it manifest in praxis what we are preaching here, or analyzing, critiquing, and deconstructing. How do we really make the change? So I think it could be a call from an organization like SCRI banding together with other organizations such as the Global South group that exists in other places in Latin America, with whom this organization has not cooperated much, and start, promoting, I think, through publications and webinars and educational strategies and postings in the website that this work is being embraced. I think that will promote to disseminate more of the work that other people are doing, and for us to be more knowledgeable of what is happening and what kind of toolbox can be created towards building decoloniality.
And I'll chime in since the bell is ringing, the Pacifica bell, on that piece. I'm always so deeply inspired when Nuria speaks and presents, because her presentations always offer clarity to stuff that I still haven't quite articulated yet. So I'm always grateful. But one of the things that came up in her presentation was this statement: there can be no universal pandemic response because the root cause of disparities within the pandemic are rooted in coloniality. So the response has to take into consideration that arc and historical legacy. So, in my work, and I see this on the front lines, and what's inspiring about these presentations is on the front lines, the narrative is still the same: race as the root cause of disparities instead of racism. And I know in my work, that's something I emphasize. But even right now, with regard to a statement idea, how can even small shifts begin to happen through the statement, through the communities we work in, to shift the narrative? Even calling up the local news station, KPFA, I'm here in the Bay Area. KPFA and say, come on, guys, we need you to shift the way you're reporting the story. You can't say that there are all these numbers, disparities racially, without giving a clear analysis and context of how that disparity has occurred. That frontline workers, our farm workers, people in service jobs, these are predominantly Latinx, Black, brown folks, right? So it is an entire labor structure that has these people positioned to be more exposed, at least from one perspective. So the response has to incorporate that too. So thank you, Paul. And of course, as always, thank you, Nuria, for the presentations.
Can I just share one more perspective? It might not be very helpful because I'm speaking from the research hat, but I really, really think about the importance of building evidence. I know that scientific knowledge is not necessarily the most decolonizing tool, but I think, at least speaking from public health, we really have good evidence of, racism caused health disparities, but we don't have as much evidence on or practice-based evidence on what are the best methods to achieve social justice. So as you continue to think and engage in your work, please, help to build the evidence on the best how-tos to make these things happen. And that is, to me, my strategy for putting these things forward, is what can I do to build some evidence for doing this.
Thank you guys, everybody, for being here today. I'm always humbled and hopeful whenever I hear Nuria, and then to meet Paul and to be introduced to your work. It's been, I don't know, I'm just very grateful. So I know that Jean is recording this. I'm not exactly sure how people would access this later. If you could remind us, in case there's some folks who are wanting to share this with their colleagues.
It'll be on the SCRA YouTube channel, along with another presentation from Nuria that was also absolutely amazing. So.
All right. Again, thank you guys, everybody, for coming today. If you want to unmute yourselves, and round of applause for Paul and Nuria. I really, really appreciate it. Amazing work you guys did, and really just present these odd hours that we gathered today. So thank you.
Bye, everyone. So nice to meet you.